And we are going to start with Councillor Margaret Eames-Petersen, who is a county councillor from Hertfordshire, but also has a background in public health, which I think is going to inform your presentation. Margaret.
I hope so. If I stand up, am I blocking somebody's view? Would you rather I sat down? Would it be... Pardon? Better standing up. Okay. So, this is my first conference, and I'm actually a fairly new councillor. I was elected in May this last year. But I'm not new to health. I have been head of public health intelligence. In fact, I was the first head of public health intelligence in the country. And I became head of public health intelligence for Hertfordshire, and then I was asked to cover Hertfordshire and Bedfordshire. And so I'm going to let you into some little secrets on the way. Well, they're not really secret, but it's actually why I really believe councillors can make a difference for health. And it's all about asking questions and making sure that you too can notice when we're maybe measuring the wrong thing, particularly to do with inequalities in health, or we are not actually looking at the right outcomes. So I'm going to just romp through this because I've only got 5 minutes. Now, I'm sure you know about the Health and Wellbeing Board, actually existing in the councils. In ours, it's in the county council. And we've got also the transformation plans that are now been around for over a year. A bit more tricky getting delivery of those in our area anyway. So they're a forum for discussion, asking questions, asking about public health, population health, wider determinants of health. We don't get enough questions about how are wider determinants of health really affecting our health. And thinking about health priorities for the coming year and commissioning. I'm going to come to CCGs in a minute. They're our sticky area in Hertfordshire. But check, are they good measurements? Are they good measurements of both need and service? Are we asking for the right measurements? And then also communication and how health is everybody's business. It's not just public health, it's in every department. I'm going to come to that. But the outputs from the Health and Wellbeing Board are JSNA and the Health and Wellbeing Strategy. And that JSNA is really, we can do something about asking questions about that.
People are allowed to ask if they don't know what the acronyms mean.
Oh yes, Joint Strategic Needs Assessment. Please don't let me, thank you, Martin. I'm somebody who often puts my hand up to, on behalf of other people, to unpack acronyms. So sorry about that. Yes, Joint Strategic Needs Assessment. So in the Joint Strategic Needs Assessment, they actually really want to cover all health needs. They often don't. They often take a theme. But these days, a Joint Strategic Needs Assessment should be online, and we call it a rolling JSNA, to be updated regularly. Now, realistically, that might mean every 2 years, or it might be staggered. But because it's online, there are certain subjects that will be updated at different times during the year for various reasons. And in fact, our public health intelligence teams have got smaller, unfortunately, since 2013. So in order to spread the load, they often have to do it in a staggered way. I'm going to skip through some of this. But in the JSNA, you should have health profiles of your area, where you're standing as a councillor, maps, time trends, wider determinants, comparative data across wards within the local authority, and then local authorities within a county, a region, and across England. And that is your data to get the commissioning of health in the future. So now we, Hertfordshire, have just been through an LGA peer challenge, which actually was very good. And if you haven't had that yet, try and get your council to be part of the LGA peer challenge initiative, where they come and sort of scrutinise what you're really doing. And particularly, they're very good at looking at inequalities in health and interventions. And what came up, we've just done it. I've just sat in on Monday on the report of the LGA peer challenge. This came up for Hertfordshire, although Hertfordshire seemed to have quite a good bill of health. Beware of self-congratulation. But the prevention agenda, needing to be really inbuilt into the council, thinking if we prevent things, it really saves money in the future. But it is very much a long-term thing. You have to think ahead and why it will save money 10 years' time, which, yes, with elected bodies, they're not very good at that. Social prescribing, learning from other local authorities, best practice, enabling communities to take decisions to be healthy and help each other within a community, like walking buses and mental health groups, lots of things that actually a community in a locality can help people be healthy. Sharing swimming pools, a school that has a swimming pool, sharing it with the community. Scrutinise. Now, this is very interesting. In times of austerity, we really need more public health intelligence in order to make the right priority decisions. So in our area, particularly, these are not new, but true probably of all LAs. How to stop smoking, reduce obesity, increase exercise, sensible drinking, sexual health, mental health, and child and mental health. Child and adolescent mental health is actually a key issue at the moment. So using us as councillors, we can initiate partnerships. We need to talk to our colleagues who sit on the other committees. And the public health intelligence is key to reducing our health intelligence and inequity. And I'm going to just show you that inequity isn't quite the same as inequalities. But you can get involved. Anyone can get involved. Health is everybody's business. And we've just had published in the local LGA magazine this month for February this initiative about health in all policies, HIAP. I don't know how many of you read the article called Justice, Health, I forgot what it's called, Matters of Justice, I think it's called, but it's really meaning health in every committee of the council. So this is a little example. After I was in Hertfordshire and Bedfordshire, I actually sort of had an ambition to work in the poorest local authorities in the country. I did quite a few boroughs in London, building up their teams. And this was Barking and Dagenham. Now, this isn't too difficult to look at where did Barking and Dagenham come in the whole of London. They were second worst for preventable premature cancer. They were third worst for childhood obesity. Now, when you see those sort of stark results, and you do need to see, is it significant? Is it above the red line? It is. Those should be our priorities for the coming year. And I want you to try to interpret these graphs and realise when can you help to push the right agenda. And then what I've just said, really, health and social care and the wider determinants. Health is not only on the Health and Scrutiny Committee, which I now sit on, but it's in, and not only in public health prevention and performance, but in all those other departments too. We were thinking about planning, and I represent Hatfield North. British Aerospace shut. 10,000 people are now living on the old British Aerospace runway, and Running Hatfield Borough Council, which is Tory, never built the infrastructure. They never built the GP practices. They haven't built those things that really go for health. We need people in planning understanding health. So there you go. Even if you're not on the Health and Scrutiny Committee, you really count in one of the other committees. And I wanted to mention the Marmot report because the Marmot report on inequalities and recognising early start, housing, transport, green spaces, it all counts towards our health. That has been adopted in every local authority in the country, I've heard. So that we can argue with. Read it, use it in debates, use it to get it at the front of the agenda. And what are our tools? We do need the right statistical methods. And Martin actually was just talking about possibly having a sort of consultancy within the Socialist Health Association to be able to, for councillors to know, are we really doing the statistics right? If I tell you what we've done, is it right? So that every councillor can have the equipment to question things. So health needs assessment, health equity audit, I'm just about to talk about, time trends. We need to see which direction we're going in with health. comparisons, priorities, and cost effectiveness. We need to be wise about money. We need to think which initiatives are going to cost more, which will cost less, and which ones achieve the same thing. So this is I said I'd talk about inequity. Inequity is a bivariate thing. Really, what we're trying to get rid of is inequity. That is a graph of the inverse care law. It could be just like this, but it's really saying those with the most need are getting the least service. And those with the least need are getting most service. And this is often happening at the moment under our Tory government. And I just want to show you a little example in some of the richest places why by averaging things out, you then don't see that within a rich place there are the poorest areas getting the worst treatment. And we need to be councillors that champion those people. So that's the situation we want. And the Labour government, I actually am quite a champion of the health equity audit. And if anybody wants a copy of this slide now, I've done 5 copies of it because it's a 6-arrow process. It's about agreeing what is our most serious health issue, agreeing what we might do about it and what the gap is, why it's bad, and thinking of the right intervention and getting partners to agree how we're going to do the intervention, get funding, but then we measure the gap at the beginning, we measure how bad it is at the beginning, and we measure after the intervention as well, so that we get our evidence.
I'll put it on the website.
That's it. Perfect.
So, and I'm just going to tell you, this is a historic story, but when I was head of public health intelligence in Hearts and Beds, I noticed in St Albans, I calculated something called smoking attributable mortality, which is now used on the Public Health England website, but I managed to get it, done in Eastern Region, and then it actually became part of NSHOD, the statistics. So it is now used nationally, but then it was a new measure. And I want to just show you, if we ask the wrong question, we're not going to improve health. So everybody was using this thing called quit rate. Do you know what quit rate is? Quit rate is how many people give up smoking out of how many people arrived at the smoking cessation service or the stop smoking services. And I said, but the trouble is we're not actually even getting the right people, the people who are dying from smoking, to come to the stop smoking service. What are we doing? They were good people in the stop smoking services. And then I looked and saw where they were located. And in St Albans, which is a rich place in general, but there is a council estate called Sopwell Estate, which is very poor. I'm just going to show you what this was in 2002. I know it's historic, but I just want you, to see that here we've got the inverse care law going on. You've got this line going in the wrong direction. You probably can't see it at the back of the room, but there's a spot there that is one of the wards in St Albans, and there are these spots where this axis is saying smoking cessation uptake, which I could measure from the stop smoking service. And this is smoking attributable mortality for men over 35. And you can see this was in the previous 4 years where they were dying from smoking. And this had the highest death rate, standardised death rate, in the whole of St Albans, 0 uptake of smoking. And I showed this to what was then the Director of Public Health and the local authority, and they said, that's terrible. Why is that happening? And then you looked, and all the stop smoking services were next to the GP practices, which were in the rich bit of St Albans. And people, they hadn't really even got the place, them located in Sopwell on the council estate that really needed it. And that was the same of some of these as well, actually. So anyway, they moved them, and then we measured it 4 years later. Like I said, we did the health equity circle, and then it went in the right direction, and it's got better since then. And in fact, Fiona Adshead, who was the CMO, deputy CMO, I had to give a presentation at something to public health, and I was only allowed to show 3 slides, and I showed this, and she said, I really want that. That's really... and she started using it. But it just shows that if you... quit rate was actually the wrong thing to ask about, because that was 68%. It looked really good. But actually, it was disguising what was really going on in the poorer wards. I've mentioned partnership and how we need to communicate those health needs with other departments of the council, all the departments of the council, transport, housing, environment, planning, all of them need to understand our areas and health needs. So I've mentioned sharing the public health intelligence. I am a champion for public health intelligence. Working with our other directors and departments in local authorities. But I've put CCGs in red there because they've been the most difficult in Hertfordshire to actually engage with. And strictly, they should be sharing exactly the same public health intelligence as the public health intelligence in the local authority. So we have a challenge. We are gradually, they've been coming to the Health Scrutiny Committee. Finally, they wrote letters and didn't come to start with. But and we have one CCG overspent by £45 million at the moment. So they're not doing very well, really. I think they're on a learning curve since 2013. But we need to help them, and actually it would save a lot of money to share the team of public health intelligence with CCGs. Right across the country, that's true, actually. So that's another little thing to think about. They should be contributing, I think, to the pay of the public health intelligence team. And then saving costs, win-win situations, things like walking buses and cycling. You can see that's exercise, lower carbon footprint, reducing obesity. But we do need to then argue for safety, getting those cycle lanes put in place, which does cost money with highways. But the business case is there to save costs later. And the other thing is listening. I'm going to say a little bit about listening to our areas. We need to understand the language of our areas and that they understand what we're talking about. Oh, yes, I'm just saying this is for the agenda of the elections in May. We need to understand the wider determinants of health and why money needs to go to the poorer places. I will just say I am one of 9 Labour councillors in Hertfordshire out of 78 councillors. So I am slightly swamped by the Tories, but I do believe in arguing our case because the evidence does speak for itself, and I hope we're getting somewhere. We have won some debates. And this is the last bit, just showing you if you ask the wrong questions, you don't necessarily get as much, you don't get focused on the right areas. So childhood obesity is a really good example of how everybody's involved. Health, education, transport, sport, green spaces, fast food outlets, shops, and why we need to monitor the data and whether we're improving things or not. And actually health working with schools, which is quite tricky. We've just started a family health service, but we need to link it to the schools as well, which is doing children from 0 to 19, not just children, the early start children. I'm just going to show you something about when we measured the National Child Measurement Programme in Barking and Dagenham. This is like hotspots, a map of Barking and Dagenham where I was as well. Difficult area, not very Labour yet. But this is children who were very overweight in year 6, just in 2012. And I then said, I don't just want this year, I want to see what really has happened in the last 5 years. And in fact, you can link the same child's data now, age 5 to age 11. They don't often do it, but you can ask your public health intelligence team to do it, to see which children have really gained weight or lost weight, and helping them to motivate, having self-esteem that they want to, by the age of 11, if they're a little bit overweight. And they can be overweight because of not having a growth spurt. You know, it's not always that they're always going to be overweight. But this is really showing schools that weren't doing very well because over the 5 years from 2007 to 2012, there were some areas that were actually the percentage change had gone up for the whole of the 5 years. Now, those are the ones that really were worrying, you see, because they hadn't managed to make a difference over a much longer period. And of course, they are different children each year. So thinking about how we can ask the right questions, not just what is it now, but where were the increases in obesity over time. I think that's the end.
Fantastic. Great starting point, lots of information about how you can do things. We've got a good range of types of authority as well.